Welcome to the Pain Assessment and Management in LCC webinar. My name is Alex and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Michelle. You may begin.
Hi, this is Michelle Carlson, and I am with Health Insight, the QIN/QIO for Utah. And I am proud to introduce our guest speaker today, who is Dr. Sheida Talebreza. She is the assistant professor at the Division of Geriatrics, University of Utah School of Medicine. She's a palliative care specialist for the home-based primary care program for the George E. Wallen Salt Lake City Veterans Affairs Medical Center, and she's also the medical director for Inspiration Hospice. So without further ado, I will turn the time over to Dr. Talebreza, and she will tell us a little bit more about herself as well.
Thanks so much, Michelle. I'm so happy to be here. I think this is such an important topic, and I'm very excited to present this to everyone today. I just want to let you know this is a talk that I usually give in a 2-hour session, assessment and management separately, so I condensed it down a little bit. I included many of the slides, but I want to warn people that we'll be going sort of at a fast pace. And on this title slide, you can see that I have my email address included. So if there's any questions or concerns or anything that we didn't get to during the time of the webinar, I'm very happy to respond to questions and can share my work phone number as well, and we can talk by phone. So we'll get started. And the outline for the assessment portion, this is the first half of our talk, is just very briefly talk about what is pain, the prevalence of pain in older adults, some special considerations for geriatric patients. We'll review the types of physical pain, and then we'll spend really the majority of this half of the talk looking at geriatric pain assessment, the physical pain history. There's a little mnemonic that we'll go over to help us remember how to do that assessment. We'll also talk about how to assess patients in pain that are cognitively impaired. And then just another reminder too, so the focus for today, both with assessment and management, will be very clinical. So we'll give you a lot of tools to clinically manage and assess geriatric patients and then to manage their pain as well. So just a brief definition about what is pain. So the definition is it's an unpleasant sensory and emotional experience that's associated with actual or potential tissue damage. And also it's important to know that pain is also a perceptual experience that has an impact on all aspects of a person's emotional, psychological, social, and physical functioning. So for what we're going to focus on today is really going to be physical pain, but it's really important for us to understand that emotional and psychological and social components can really add to your physical pain, and physical pain can then also influence your mood and have a lot of impact on your psychological and social well-being as well. So again, stay focusing on the physical, but important to know that it has so many domains that can affect it. So pain prevalence in older adults, substantial, I skipped over one slide. And that's just sort of that same idea of psychological, social, and spiritual problems can affect a patient's pain perception and tolerance. And another reminder that it's really important for us to include a multidisciplinary approach to our assessment and treatment for treatment to be effective, because it is such a holistic problem that just focusing on one aspect of physical pain without looking at the psychological, social, and spiritual influences really wouldn't be a good way to manage someone's total pain. And so again, just an importance of multidisciplinary approach so that we can really manage this well. Substantial pain is experienced by a geriatric population. So anywhere between 25 to 50% of community-dwelling adults have complaints of pain, and anywhere between 45 to 80% of nursing home residents. So this is a significant problem for our geriatric patients. Geriatric pain is also undertreated, and there's a lot of factors that contribute to this. One is that geriatric patients may minimize their symptoms. So they may not voluntarily report pain, or they may be unable to report pain due to cognitive impairment. And then in addition to patients not being able to report their pain, clinicians may actually inadequately assess pain. They may treat pain with ineffective therapies, or they might encounter adverse effects that may limit effective therapy use. So when we talk about management, we'll look at ways to sort of make sure that we're using the effective therapies, and that if we are coming up to some side effects or adverse reactions, how we can manage that to optimize pain management for patients. So this slide is just a review of the types of physical pain. And so there is a resource for you to know that depending on the source of pain, there will be a different description of pain from the patient, and also different treatments that will be important for them. So with nociceptive pain, the source is usually tissue injury. It'll be with patient's bones or soft tissue. And examples of that are arthritis, fractures, bone nets. Nociceptive visceral pain is going to be from cardiac or lung sources, and examples of that are renal colic or constipation. And then neuropathic pain is sources either the peripheral or central nervous system, and then some examples are diabetic neuropathy or trigeminal neuralgia, post-herpetic neuropathy. And so again, we'll have in an upcoming slide the description of what the pain might feel like for patients, and then also effective treatments for each of these types of pain. This is a nice little mnemonic that I like for our pain assessment. So it's a very thorough way of looking at pain, and so it's PQRST. And the letters stand for provocative or palliative factors, quality, region, severity, timing, and treatment choice. And so we'll go through each one just very kind of briefly. We'll spend a little more time with severity just to go over how you can go through that history. So when it comes to provocative or palliative factors, the question that we're basically asking patients is, what makes the pain better and what makes the pain worse? And so that can be really helpful, because sometimes just from the history alone, you can get a lot of diagnostic value without maybe even doing imaging. So for instance, back pain that is increased with standing and walking and relieved with sitting or lying in the fetal position can be due to lumbar spinal stenosis, and you can get that just basically from the history that you're getting. Pain that's brought on in the back by bending, lifting, or unguarded movement may be due to an unstable lumbar spine, and this can be caused by lumbar degenerative disc disease. And so again, in the long-term care setting, based on a patient's goals of care, sometimes you can get really valuable history just by what makes this pain better, what makes it worse, and you may or may not need imaging depending on the history that you get from the patient. So this is valuable information that you can gather. So looking at quality for the patient, so we looked at that. Apologize. I'm having challenges with advancing the slides. Oh yes, okay, we're at the right and one more. There we go. So now we're just, I have to thank Michelle, she's helping me with advancing the slides. And so thank you everyone for being patient as we do this as well. So with the quality of pain, again, asking the patient if they can describe the pain in their own words is really the best way if you can. And then the quality of pain also will relate to whether it's somatic, if it's visceral, if it's neuropathic. So this can actually give you some really great information. Aching, stabbing, gnawing, or thrawing, if it's dull, colicky, squeezing, deep, or cramping, and then sharp, burning, pricking, or tingling. So that sharp, burning pain tends to be more associated with neuropathic pain. Aching, stabbing pain can be more associated with the somatic pain, and then dull, colicky, squeezing, deep, and cramping more with visceral pain. So the words that people describe can kind of give you an idea of the source of the pain too, and then we can make sure we get adequate treatment for the patient. If the older adult has difficulty describing the pain, so if you just ask an open-ended question about, can you describe your pain for me, and they aren't able to tell you, then you might want to use some of these words and put that out there for them as something as a way to sort of help them be able to characterize their pain. It's always best to ask them open-ended first, but if they can't describe it, then to use some of these words and see if any of those click with your patient. So the region of the pain can be really helpful as well. One thing that you can use is a pain map, and these are just found on the internet where you can print them in sort of large print and ask the patient to draw on the map where they're having their pain. The reason this pain map can be helpful is it can help you define what type of pain the patient is having, and also, for instance, in the long-term care facility, if you have a pain map and the patient has cares that need to be done, if they need assistance with getting out of bed, if they need assistance getting into the shower or dressing, and you have your pain map, then you can show that to your interdisciplinary team, to your aides, to your nurses, and really try to minimize movement or pressure on the areas that hurt the patient. So this is something that can be a useful tool, and it's very easy. There are free maps on the pain maps that you can print off the internet and use with your interdisciplinary team. The severity of pain is something that I think many of us will be very familiar with. So this is the whole idea of how bad is this pain? How severe is it? And from the World Health Organization, basically they have these rating scales where if the pain is 0, then we know the patient has no pain. From 1 to 3 is considered mild pain, and that really should be background pain. It shouldn't interfere with someone's ability. In palliative care, we oftentimes try to get at a goal of less than 4 for someone. So if someone's rating their pain of 1 to 3, that's something that might be a target area of what we're trying to reach for, because oftentimes it's not realistic for us to be able to get someone's pain to a 0. 4 to 6 is moderate pain, and this generally interferes with function and sleep. And 7 to 10 is considered severe pain, and that generally interferes with function, sleep, and concentration. And so when someone's reporting a 7 out of 10 or anywhere between a 4 and above, we really want to try to get them a little bit lower on that pain through our interventions, whether they be medications or non-pharmacological measures to try to get them down there. In addition, sometimes some patients report really high pain, and that's just their baseline. So when a patient reports 7 out of 10 pain, but they look like it's not interfering with their function, sleep, or concentration, some questions that I will ask is, what's tolerable to you? And what's your goal? Where would you like us to be? So sometimes patients will say, oh, I'm at 7 out of 10 pain, and when I ask what's tolerable, they say, oh, yeah, that's 7 out of 10 is tolerable for me, or 6 out of 10. And so knowing and calibrating it to each individual patient can be very, very helpful as well. Now we're going to look at a couple instruments to help you guide some pain scales so that you can be able to use these in the long-term care setting for evaluating and assessing your patient's pain. So there's the numeric rating scale and the FACES pain scale, and both of these have been validated in older adults as good tools to use. They're reliable tools. They are easy to use. The numeric rating scale requires that the patient can hear or has or vision, so one or the other, and cognition. The FACES pain scale requires vision, attention, and cognition. So we'll show these to you and sort of how to use them. You may actually be fairly familiar with them. So the numeric rating scale is where you can just essentially ask a patient if they cannot see and can hear. You can say on a scale of 0 to 10, with 0 being no pain and 10 being severe, where would you rate your pain? And so that the numeric rating scale, that will just give you a number. And again, 4 to 6 being moderate, 7 to 10 being severe. For patients that can't hear, you can print this out for them and actually have them and print out a set of instructions that they can read, and they can point to the area on the scale. So that can be helpful for our patients that have impairment with hearing. This is an example of the FACES pain scale, and again, you would let your patient know that based on 0 being no pain and 10 being the worst pain that the patient has, to pick what FACE correlates with how they feel. And so important things to know about the FACES pain scale is it's not for us to look at the patient's face and try to determine which face we think fits with them. It's again their self-report where they would pick the face that they feel corresponds to the measure to the degree of pain that they have. This Long Baker Faces Scale was developed for pediatric patients. Hasn't yet been validated for older adults, but the faces are a little more expressive, and so that can be helpful. The issue with Full Faces Pain Scale, with the Baker Long a little bit more, is actually that the tears. And so one of the concerns is that men may not point to the worst pain because of the tears on the face, and also geriatric patients oftentimes underreporting pain can be an issue, but specifically with men, wanting to be a little bit stronger, they found that they tend not to pick the higher levels, especially when there are tears involved. So just something to be aware of. The other thing to be aware of with the pain scales is that they're not interchangeable. So if you're starting off with a numeric rating scale, you really need to stick with that scale unless it's not working, and then switch to another scale and stick with that. So you can't, they're not usable. I can't start off with the faces scale and then move to on a 0 to 10 scale and then go back again, because they don't correlate with one another. So if you're using the numeric rating scale before you give someone pain medication, it's important to use that scale, and then when you come back to reassess them, to stick with that scale and use that again. It's been shown for cognitively impaired patients that their report, if they have mild to moderate cognitive impairment, that they can self-report pain. So people who have Alzheimer's disease, who have dementia, and it's in that mild to moderate degree, they can be fairly good at reporting their own pain. And so the numeric rating scale and the FACES pain scale can actually work for those patients with cognitive impairment. For people who, other ways to help with cognitively impaired older adults to assess their pain is to use their self-report and then your observation. And so if there's a big discrepancy, then you may be concerned that they're not able to self-report well. Also asking them if there's a big discrepancy, just that example of my patient who said they were in a 7 out of 10 pain, but a 7 out of 10 is acceptable to them. So I was asking them to calibrate their scale, and what's acceptable can also be helpful for you as well. Knowing to ask the caregivers or family members of the patient if they can give you feedback about, how bad is this pain? How is it impairing the patient's function? Are they spending more time in bed or in a chair and they're not able to do the activities? That can be really good information. In a long-term care facility, when a patient's first coming in, getting that information from patients, and then staff can be really great at reporting that. So as they know what a patient is able to manage and what limitations they have, they can really give you some great information about that. The other thing that you can try to see if in a patient that's cognitively impaired and you're not sure if the behavior that they have is due to pain, is to try a small amount of pain medication for them. So schedule Tylenol has been really effective, and trying that to see if behaviors or limitations in function improve after you try the medication. So the interdisciplinary, there was an interdisciplinary expert consensus statement on assessment of pain in older adults, and they couldn't come up with a definitive recommendation for any scale with patients for severe dementia. So in mild and moderate, they said try self-report, and then also get the assistance of caregivers and family. Try maybe some scheduled medication. Those are some really good measures for assessment in an older adult with mild to moderate dementia. But when it comes to severe dementia, they couldn't really come up with a consensus, but they do have some tools that they say may be helpful. So the promising tools are the PAINAD and the Dolaplus 2. I have examples, and you can Google them and download both of these. The American Academy of Hospice and Palliative Medicine oftentimes sort of talks about the PAINAD. So we'll look at those just very briefly. The PAINAD, the limitations for it is it's a 60-item checklist, and it takes more than 5 minutes or around that amount of time to administer. It's been validated. It's inter-rater reliability shows that when one person uses it and then another person uses it, that they come up with very similar ratings. So that's good with that tool as well. With the Dolaplus, it's a little simpler. It's a 10-item scale. 10 10 items from a 0 to 3 scale. Takes less than 5 minutes to administer, and it's also been validated. Personally, I use the PAINAD the most. That's a 5-item scale, 5 items, with a 0 to 2 scale. It takes less than 5 minutes to administer, and we'll just go through and sort of look at each of these very briefly. They're not going to show up too well on the slide set, but this is an example of the PAC-5, and you can see that there's quite a few questions that you're going to have to answer, and so that could be a barrier. That can end up being a little bit problematic. With the Dolo Plus, again, 0 to 3 on the different scale, and then you score the different items and come up with a number. With the PAINAD, the nice thing about it is it does come out to a 0 or to 10. So if there's 0 on all of the different measures on breathing and vocalization and the other measures that you'll see on the next slide, then the patient's pain would be 0. If their level is, they might pick a 1 on certain measures or a 2, and so then you go through and add that score up, and that final score will come out from either a 0, 2, or 10. The items that are looked at are breathing, so that is whether or not it's just normal, whether the patient has labored breathing, or if it's noisy with long periods of hyperventilation. For vocalization, if there are no problems versus moaning and groaning, or repeated calling out, loud moaning or groaning, and so then you would go through and measure it according to that. Looking at facial expressions, looking at body language and consolability. So these are all measures that you can use. What they found with the PAINAD is that there are other problems with dementia-related behavioral problems that may not be pain that could also cause someone to have a higher score. So dyspnea could add to the score that may not be painful, but someone may just have some shortness of breath. Someone may have changes in their body language based on a dementia-related behavioral issue that may not be pain-related. So just, it is a very good tool. It is validated, but just to really look at the broad picture and think, if you try pain medication and the PAINAD is not really going down, it could be that that's not necessarily an effective pain medication, but we're also knowing with the PAINAD, could it be another source of problems for the patient? Just a reminder, again, this is more a clinical talk than a regulatory talk, but knowing that the MDS indicators of pain, if you look at them and then look back at your PAINAD, you can see that they're very, very similar. So there's some good overlap with the MDS indicators and the PAINAD. So that might be something that you might want to use. There are tools that you can purchase, I know, for long-term care facilities that have a way to record the pain medication. They have the tools that basically also show your assessment. So you can, it has a numeric rating scale or the FACES scale and even the PAINAD all on the tool, and you can describe which assessment you've used to describe the severity of pain for patients and what intervention you've used and how the intervention is changing the patient's pain. And those can also just be found by Googling pain severity scales. So the last two topics for pain assessment are basically the timing of pain and treatment tried. So we'll look at timing first. And so when we talk about timing of pain, when does it start? How often does it happen? And the duration, how long does it last? And again, these can be really good tools to help you figure out what type of pain the patient has so that you can come up with an effective intervention for them. And then treatment tried is really looking at what are the medications that the patient has been on. So in our patients who come into a long-term care facility or have been there for a while and they have pain that's persisting, knowing, well, what medications have we tried in the past, what has been useful, what was the dosage and the frequency, what types of over-the-counter medications or natural remedies have been used, what sort of non-drug treatments have been used, and assess all of these for their effectiveness and adverse events. Sometimes really looking at non-drug treatments. Has massage helped? Has walking helped? Is it due to immobility? So not only what are the prescription drugs, but what other sort of heat or cold, what other things might help this patient to manage their pain? And so just putting it all together when it comes to assessment. So reviewing for somatic pain, we talked about the source, again, with that tissue injury with bone. The type of history that the patient's going to give you is that aching or stabbing or gnawing or throbbing. So those are the words that you expect to hear. When we bring the region together, we'll see that it's well localized. Timing tends to be constant. So these are those PQRST questions that we're looking at. So you'll tend to hear this back from your patient. And the effective medications that we'll use for this are Tylenol, opioid medications, and then physical therapy and cognitive behavioral therapy have also been shown to work. And what you'll see in parentheses with the A, B, and C is the level of evidence. So A being very strong level of evidence that medication works for this type of, or intervention works for this type of pain. So Tylenol being a very good, acetaminophen being a very good treatment option for this pain, well studied, good evidence for that. And so now we'll move on to our next one, which is visceral pain. And we'll see that really the way that we want to manage visceral pain is by treating the underlying condition. And then when you look at the history, the words that people will describe for the quality of that pain, pulling it together again as you're doing your assessment, they'll say it's dull or it's deep or it's cramping. And then the region usually isn't one really well localized location, but it's very diffuse. And the timing can be intermittent or paroxysmal, so it can come and go. And again, this would be that renal colic or it could be constipation. And the way we want to manage this pain as much as possible is to treat the underlying problem. So if someone has constipation, we want to treat their constipation. If we treat their constipation with an opioid, we're going to just worsen the constipation. So very important for us to get to the underlying cause. And then neuropathic pain, it's going to be described as sharp or burning, pricking, or tingling. So important for us to sort of distinguish that because, again, if it's somatic pain, remember Tylenol was such a great option for us. With this neuropathic pain, tricyclic antidepressants, that's what PCA stands for, selective norepinephrine reuptake inhibitors, SNRIs, which are a type of antidepressant, or anticonvulsants, medications like gabapentin, can be used very well for these. They all have strength of level evidence A for neuropathic pain. Opioids have some effects, so they're level evidence B. Topical anesthetics, kind of a little bit weaker on the evidence for that, maybe not has been as well studied. And then physical therapy and cognitive behavioral therapy also have some indications for these. And so again, just a really good assessment, knowing that when you describe your pain and say that it's sharp or burning, then we're going to want to look towards other interventions rather than maybe the Tylenol. Tylenol being very, very effective for the somatic pain. And so just a summary of our assessment slides, that pain requires a thorough assessment to determine its source, severity, and impact, and that you can use this mnemonic with your PQRST to be able to ask the right questions for people. And then also to remember to use the same pain severity scale to assess response to treatment. So if you're starting off with a rating scale or using the SACES scale or the PAINAD, that you kind of can't mix and match them, you need to stick to one. And a really great idea for assessment is to assess the patient before they get their pain medication, get your number of their pain, and then within an acceptable time frame, which we'll talk about in management, to reassess and make sure that that pain medication is bringing the pain down for them. And then to be able to differentiate between the different types of pain, somatic, visceral, and neuropathic, because the treatments that we're going to offer patients differ. So now we'll move into management. And so with management, we'll look at the World Health Organization pain letter. We'll talk specifically about acetaminophen. We'll talk about NSAIDs, tramadol, opioids, and I've included slides on adjuvant medications as well, and I'm hoping that we'll have time to get through those. But if we don't, they will be there for the slides are there for you. So the World Health Organization has a 3-step ladder for the types of medications that you can use based on the patient's level of pain. And so what you'll see is if someone has a 1 to 3 mild pain, that might be something that would work well with acetaminophen. NSAIDs might be a good response for that. So if that's where they're starting off and it's not tolerable, it's interfering with their function, or it's really disturbing to them, it's not mild pain, you may want to start more at these types of medications. When we get into that 4 to 6 moderate pain, and it's more than what the patient what they are able to manage, and it's more than where their target is, then some medications that you can think about are oxycodone or hydrocodone, codeine, or Tramadol. These are all medications that are combination medications. So it's acetaminophen with codeine, acetaminophen with hydrocodone, and acetaminophen with oxycodone. In this degree of pain, the acetaminophen is a limiting factor because there is a ceiling dose on the amount of acetaminophen that you can take. There will be a limit or a ceiling dose on the amount of medication that the patient can get in a 24-hour period. So that Tylenol, that acetaminophen, is the limiting factor. When people have 7 to 10 severe pain, then the medications that are oftentimes recommended are morphine, oxycodone, hydromorphone, methadone, or fentanyl. These all are medications that don't necessarily have a ceiling effect because there's no medication, there's no toxicity built in just with the medicine itself. You have to just be cautious that they don't have side effects. Acetaminophen has toxicity to the liver at a certain dosage. Morphine, oxycodone, methadone, and fentanyl, if someone doesn't have liver or kidney impairment, there are no maximum dosages, but you do have to be careful to watch for side effects. And we'll have some slides to talk about those side effects to be careful of. So just going into acetaminophen, this is actually recommended as first-line therapy for mild to persistent pain in older adults. Interestingly, it's not NSAIDs. So in older adults, the first-line therapy for that mild or to moderate pain is going to be acetaminophen. It's really found to be that level A of evidence, effective for musculoskeletal pain from osteoarthritis. It's really good for chronic pain, and it's better if it's scheduled rather than as needed. So if you have a patient that you're noticing, even maybe on that moderate spectrum, that 4 to 6, scheduling some Tylenol for them can be very helpful. And the starting dose for an older adult in your long-term care facility or a frail younger adult is anywhere between 325 to 500 milligrams every 4 to 6 hours. You want to make sure that you have less than 4 grams in a 24-hour period, less than 3 grams in a 24-hour period if the patient is on Coumadin or if they have liver impairment, and then not to exceed more than 1 gram per 4 to 6 hour period. Sorry, I think I skipped ahead. Apologize. One back. Right. And so that's just sort of what we talked about. The other point that's important with this slide is to know that the other medications that the patients are taking, because patients often have, and not so much maybe in a long-term care facility, but Loratab and Tylenol together with other medications that have Tylenol in the home setting, this can be an issue where patients don't understand that they all have Tylenol. So just a really good reminder for long-term care is on your medication administration, if you have a patient that has more than 1 Tylenol product, to put the warning of the total amount of Tylenol that should be given in the 24-hour period or with a single dose to make sure that they don't get that your med techs or your nursing staff are aware that they have more than 1 medication that has acetaminophen in it. When it comes to NSAIDs, this is actually very interesting. So these medications in older adults are actually not recommended. So the American Geriatric Society says that we should use NSAIDs judiciously, if at all, only after Tylenol or acetaminophen has been tried, and only in highly select individuals because it has such significant adverse effects. We need to use the COX-2 inhibitors medications with extreme caution, and that topical NSAIDs can be a little bit more safer, and they're effective in short-term management of pain, but there's not really a lot of long-term studies for NSAIDs. The side effects that happen with NSAIDs that we have to be really careful of are there's renal dysfunction, it can lead to GI bleeding, platelet dysfunction, fluid retention, increasing edema, worsening of people's hypertension, that can precipitate heart failure and delirium. And for this reason, actually, the American Geriatric Society recommends that if you're using it just for a short term in a highly selected individual, that the NSAIDs are okay. But long-term use is not recommended, and they actually feel that opioids are safer than NSAIDs if it's a long-term chronic pain issue because of all of these side effects that NSAIDs have. In a Choosing Wisely campaign that the American Society of Nephrologists put together, they actually recommend against NSAIDs, again, for older adults, people who have kidney problems, people who have heart problems. So these are medicines that I know we can get over the counter, but really need to re-educate the public that there are quite a few problems with them, and we need to be cautious about using them, and again, using them for short-term periods if at all possible. Tramadol, things that we need to watch out for using this medication in mild to moderate pain is that it has a really great potential for precipitating seizure risk. And so this is something that we need to just be aware of for patients that have a seizure disorder, to be cautious, and this may not be the medication that you want to use for that. It also has a ceiling effect, and we're not supposed to use more than 300 milligrams per day in patients, and in general, because of the cost, the side effects, the ceiling effect, this is a medication that we don't tend to use too much in palliative care. We use much more Tylenol or opioids rather than tramadol for those side effects. When it comes to treating moderate to severe pain, we're going to talk about opioids, and then this is sort of a little breakdown of some of the things that we'll come up with that we'll be talking about. Talk about the relative strength dosing when we look at the different opioids to see which ones are weaker and which ones are stronger. The onset, peak effect, and duration of each medication, which medicines you might want to use in renal and hepatic insufficiency, and then how to initiate immediate release or short-acting opioids, and then also some things to be cautious about with the extended release or long-acting opioids, and side effects, and then medications to avoid that are opioids in older adults. So we'll go through those. So just to give you an idea, I think this is a really nice slide to let you know that how strong the different opioids are. So codeine is relatively weak medication. 200 milligrams of codeine is about equal to 30 milligrams of morphine. And morphine is the gold standard that all other pain medications are used to sort of compare against. Hydrocodone, which is a medication in Norco and Nortad, is about equal in pain relief to morphine. So it's about the same effectiveness and the same strength. Even though patients oftentimes hear the word morphine and get really nervous thinking that that's a very strong pain medication, it actually is about the same strength as the hydrocodone. Oxycodone is even stronger. So 30 milligrams of morphine is equivalent to only 20 milligrams of oxycodone. So much less oxycodone is needed for patients than morphine. Dilaudid is even stronger. And then the fentanyl patch, the 12.5 microgram fentanyl patch is equal to about 60 milligrams of morphine in 24 hours. So fentanyl is a very, very strong medication put in patch form. And we'll talk about some of the warnings of using that medication in just a moment. Methadone has a really tricky ratio, and so this is something that you want to be very cautious if your patients are on this medication. The amount of methadone really has to do with, so if you're trying to convert from morphine to methadone, when somebody's on really high doses of morphine, they're going to need much less methadone. And so the ratios there for conversion are there for you. But with methadone, if you don't have experience with it, and if I would suggest that you engage your pharmacist and really get some help when trying to switch someone from morphine to methadone or vice versa, because it's such a complicated regimen to switch back and forth, or a palliative care expert. One of the things that, when we talk about treatments tried for assessment, one of the things that's really important is if the pain medication is not working, especially for nursing staff as they're helping physicians manage patients' pain, one thing that you can gather, some information that you can share with your nurse practitioners and with your doctors in your setting is, does the pain medication relieve some pain in at least 15 to 60 minutes? Or somewhere between 3 to 4 hours, depending on whether the medication, how it's given, if it's given sub-Q, IV, or orally. So IV or sub-Q will work much faster, and orally will take a little bit more time. So if the patient gets their pain medication and you're using your assessment score, your severity score, and they give you a number that they report, say it's a 6, and then within 15 to 60 minutes of using the sub-Q or IV medication, if 3 to 4 hours after using their oral medication, they don't have really any relief. It could be that that dose of the medication may not be the right dose for them. It may be that the dose is too low. Or it could be that the class of medication that we're using is not as effective for them. So it may be that they're having neuropathic pain and we're using a medication that's really more for somatic pain. So if they're not having any relief within this time frame, it would be good to think about, do we need to increase the dose of the pain medication for them that they're getting, or maybe switch to a different type of medication. If the pain medication relieves pain in 15 to 60 minutes or 3 to 4 hours, but wears off before the next dose is given, then that may be that the frequency of the medication needs to be changed. So increasing the dose at this time isn't going to help the patient because the pain that they're getting, the pain medication that they're getting, the dose is effective, but they're just needing it more often. And so differentiating between whether or not you need to increase dose or increase frequency is really important, because just increasing the dose for the patient is not going to help someone who's not getting it frequently enough. And so this information, if you can gather for your team, can really help so that you make sure that you're not giving them too high a dose too infrequently, or too frequent of a dose that's not at too frequent medication that's not at the right dose. And so to kind of give you an idea of how well these medications, or how soon these medications work, I created this little chart for you that lets you know morphine sub-Q IV versus PO versus the sustained release. So the onset, somebody who's taking sub-Q or IV morphine should have some release between 15 minutes to half an hour. It has a peak effect in half an hour to 1 hour, and they should have, the medication should work for them for potentially for 3 to 6 hours, and then the half-life of the medication is 2 to 3 hours, so it will clear out of their system fairly quickly. Morphine PO, you'll see the numbers there. I won't go over all of them in detail for you, but I think this is a really helpful slide for you as you're talking to your patients and they're not getting relief, to get an idea of, well, gosh, was the medicine in their system long enough for them to get relief? Also, it can be an effective tool for you when you have patients that are concerned that a family member is really tired and fatigued and having side effects from medication, and it's been 2 weeks since they had a dose of the medication. They're worried that the morphine might still be in their system. And so you can see, yeah, that really clears out of their system fairly quickly. So it can help you just understand how soon it should work and how soon it should be cleared out of their system. And so then next we have the same information for hydrocodone, oxycodone, and sustained release oxycodone. So you can again see how long it takes for these medications to have some analgesia when you would expect it to peak and have really good analgesia, and how long the medication will be in their system. And hydrocodone, oxycodone, and sustained release oxycodone, very similar to a degraded morphine and how soon you would expect to have some benefit. And it can give you an idea of when you should start reassessing pain. So with hydrocodone, the peak effect in about 1 hour, maybe a little longer for someone. So if you give them pain medication in about 1 hour or 2 hours, maybe a good time to see, hey, how are they rating their pain now? For Dilaudid and methadone and the fentanyl patch, these are some that I'm going to talk about because I think this is really important. So with methadone, you can see that a patient who's taking this is a very long-acting medication will have some analgesia right away within an hour or so. The peak effect is supposed to be anywhere from half an hour to 1.5 hours. The analgesia will work for about 4 to 8 hours. So they should have 4 to 8 hours of pain relief when they take methadone. The problem with methadone is that it's in a patient's system for up to 150 hours. So if you remember with our other slides, when you saw that the morphine works in about 2 to 3 hours and clears out of your system in about 2 to 3 hours, so by the time the pain medication wears off, it's also starting to get out of your system. With methadone, the problem is the pain medication will wear off. You will no longer have analgesia, but the medicine is still in your system. for a very long time. So what that means is you can't increase methadone quickly because you'll just stack it. There'll be a lot of methadone in someone's system if you keep trying to increase the methadone. And so for our nursing staff that's here, if you're noticing that your doctor, especially in an older adult, is increasing methadone frequently, like more than really to be safe, they say once a week might be the limit of how often you want to increase the methadone. So for somebody who's on methadone for long-acting pain, you would want to have a short-acting pain medication for them too, like a morphine or a Lortab medication that they could take as needed as a PRN, and then the methadone would only be increased on a weekly basis. In younger adults who are healthier, methadone can be increased maybe every 4 to 7 days, but in older adults it's safer to wait. With the fentanyl patch, the other thing that's kind of interesting with that is when you put the first dose of the fentanyl patch on a patient, it's going to take about 18 to 24 hours for that person to have a peak effect of analgesia. So a fentanyl patch won't work immediately. It's a long-term for people that have chronic stable pain. And it can last in someone's system for a very long time after the patch is removed as well. And so we'll talk a little bit more about these long-acting pain medications because there can be some issues with them in some upcoming slides. With renal insufficiency, the medicines that seem to be optimal are fentanyl. The patch, again, is the long-acting form, but fentanyl can come in short-acting forms. And methadone tends to be pretty optimal for renal insufficiency as well. Other medicines that can be used in renal insufficiency are the dilaudid or hydromorphone and oxycodone. Morphine should be avoided in renal insufficiency. So if you have a patient who has problems with their kidneys and they have a creatinine clearance less than 20, morphine builds up toxic metabolites and can actually lead to seizures. So when your patients that you know have kidney problems, morphine is a medicine that we tend to avoid. In the dialysis setting, sometimes morphine is used because the morphine can be dialyzed out. But for someone who has kidney impairment that's not receiving dialysis, you should be very cautious with morphine because of this toxicity. For people that have liver failure, again, morphine can be a medication that can be dangerous in that setting as well. And the medicines, fentanyl or dilaudid or oxycodone methadone can be used with caution. So in general, when you want to start a patient who's not opioid tolerant with a short-acting pain medication, it's okay that you don't have to start at the lower dose of the, you don't need to start with acetaminophen and then move on to Lortab and then move to morphine if someone is in a pain crisis. You can start if someone is in 7 to 10 pain with a very low dose of the stronger pain medications. If something to consider is to schedule the pain medications, especially in the long-term care setting, especially for patients who can't report pain to you. A very small dose at a twice a day or maybe even a once a day setting might be able to help you manage their pain. And the other thing to remember is don't start the extended release or long-acting opioids in someone who has never been on a pain medication before because we can very easily overdose those patients, and we'll talk about what that means in just a moment. These are starting doses that are appropriate for people who've never been on pain medication that are older adults. So it gives you the Norco or the Lortab, the Percocet medications, or oxycodone, acetaminophen, morphine, and hydromorphone, to get you an idea of what the appropriate starting doses are. So if you see people in your long-term care facility that are getting started and never been on opioids with 10 milligrams, that may be really just too high of a dose for them. When to titrate the doses, after how many doses can we start to look at increasing the dose for these patients? So after 3 to 4 doses would be an appropriate time to look at Lortab and maybe increasing the dose, or the same with morphine. After 1 to 2 doses, you can go up. And that has to do with the half-life of the medication. An opioid-tolerant patient is somebody who has had any of these amounts of medication for at least 1 week or longer. So So anyone who hasn't had 60 milligrams of morphine per day for at least a week is not opioid tolerant. And those are the people who really need to be started on those lower doses of medications that we showed you. So this is 8 milligrams. If one of your patients is already taking 8 milligrams of hydromorphone per day for at least a week, or they're on a fentanyl patch, this is somebody who is opioid tolerant. They're not opioid naive, and so they can actually have higher doses of medication. But if they're not taking that amount, then you really need to start very low for them. So long-acting, extended release, long-acting, that's what ERLA stands for. Medications are really only for opioid-tolerant patients. We shouldn't use them in acute pain. They're more for chronic pain. We shouldn't use them if it's a short duration of treatment, and they're not really appropriate for post-operative pain management or for mild pain. The extended-release, long-acting pain medications are for chronic pain. These medications are released over 8 to 12 to 24 hours. The pills cannot be crushed or chewed. The exception to that is methadone that can oftentimes be crushed. The patch shouldn't be cut if it's a fentanyl patch, and we should not start these medications in the opioid-naive patients. And again, you have the slide to let you know how much medication someone should have taken over a week for them to be considered opioid tolerant. And the way you build up to opioid tolerance is you start off on those low doses, you take them daily, build up, titrate the medication when it's appropriate, and then they build up to having to have 60 milligrams of the morphine or the fentanyl patch in their system. And so that's how you manage that. And be very cautious about people on long-acting medications if they are opioid naive. And then, and for the sake of time, I'll go to our next slide for us. But this is some extended release, just giving you some idea to make sure to cover for breakthrough pain, and what percentage of pain medication you would need for breakthrough pain. But we'll start moving ahead a little bit again, since we just have about 10 minutes left. These are the types of extended release long-acting opioids that are available. So methadone is a medication that has a long half-life. Extended release medications, morphine, oxycodone, or hydromorphone, are in specially made tablets that release the medication at time release. And so the long-acting, or their own half-life is long, where the extended release are formulated in a way from the pharmaceutical companies to have little bits of medication that are sent out over time. These are the starting doses for our geriatric patients, so morphine, long-acting. If someone has had for at least a week enough pain medication, at least 10 milligrams or 15 milligrams of morphine, then you can switch their short-acting morphine to a long-acting morphine. Hydromorphone and the fentanyl patch are only to be used in somebody who's opioid tolerant. So you should never start hydromorphone long-acting or fentanyl patch on somebody who has not had at least 60 milligrams of morphine or an equivalent for a week. Those are medications that can cause patients to die if we put them on someone. So in a cognitively impaired older adult, if someone asks you, well, should we just put a fentanyl patch on them because they can't swallow, that is malpractice right there. So you definitely want to start with an oral medication. The only time you really shouldn't start a fentanyl patch for somebody unless they've been on short-acting opioids or a morphine long-acting for at least a week. Medications that we shouldn't use in older adults, and these are, I think, I haven't, when I go through and take care of our hospice patients or our home primary care patients that are in assisted living and long-term care facilities, these are medicines that I don't see. So the good news is it seems like we are avoiding these medications in older adults, so that's very good. And so now, just for the last few minutes, we'll talk about opioid side effects, and these are some things that are very common. And then there's some things that are not so common. So with the common side effects, we'll talk about how to manage each one of those. For constipation, opioids decrease bowel motility. And so constipation develops in almost all of the patients who are on opioids. So if you have an opioid for a patient, you really should also have a bowel stimulant, and that's either Senate or Visceral. Colace does not work in that setting for someone. So a stool softener doesn't work. Fiber doesn't work in those patients. So if their constipation is because they're taking an opioid, if they're taking the opioid PRN, then they should have SANA or Visceral PRN. If they're taking the opioid schedule, then they should have, in very, very rare cases, people won't need SANA or Visceral schedule. Opioid-induced constipation is easier to prevent than to treat. There's no tolerance to the side effects, which means no matter how long you've been on opioids, they will stop your valve from moving. And so that's not something that you build a tolerance to. For nausea, on the other hand, that usually resolves after several days. So if your patient is concerned that they're having nausea with the medication, after several days of having it, this medication, they should develop a tolerance to this side effect. If it persists, we want to make sure that they do have a good regimen with the opioid and then they're not constipated, looking for other drug interactions. One thing that we can do is reduce the dose of the opioid medication or potentially switch to another medication if it persists. The other thing that we can also do is consider addition of an antiemetic. I know that there's restrictions with Haldol when it comes to using it in a long-term STARS facility. It is a very effective antiemetic for patients, though, at low doses. So 0.5 to 1 milligram taken before the opioid in every 6 hours for several days until they've built a tolerance to the nausea can be a very effective way if that's something that can be used in your long-term care setting, not for dementia, but for the use of nausea. The other side effect that patients complain about and are concerned about are sedation, and that you also build a tolerance to as well. And so the tolerance to the sedative effect of pain medication will develop after several days to maybe a week of consistent use. So if the patient's using it just haphazardly for the PRN, they may not build a tolerance to either the nausea or the sedation. If they're using it scheduled, that should be something that they build tolerance to. Sedation is dose dependent, and so lower dosages should have lower sedation than higher dosages. And so if someone is worried that their loved one is having an effect to the medication and you take that medication off, the sedation should not persist. It should wear off. Methylphenidate is a medication, the Ritalin basically, that can also sometimes be used in addition for people that have sedation. This is used a lot in palliative care cancer type patients who need opioid medications and then have a lot of sedation with it. The methylphenidate can help them with helping with drowsiness and energy for them. It can also be used in the geriatric setting in a very low dose, just with caution and especially close monitoring, and that should be fine. Pruritus that may develop with opioids can be treated with fexofenadine or loratadine. Those are two medications that can be very safe for older adults as an antihistamine. Benadryl is a medication that you want to avoid in older adults. It has a lot of anticholinergic effects, so it ends up for people who have dementia making their confusion worse. It can lead to falls. So if you are trying to treat pruritus just in general in a long-term care setting, or if it's because of a medication that the patient has, then these medications are much safer than Benadryl. I basically just try to boycott Benadryl for my older adults, and loratadine and fexofenadine can be really effective. And of course, trying a different opioid if someone has pruritus is also something that can be a very good idea. For urinary retention, that is something that the opioids can cause as well, and that may require a urinary catheter for people. So just to be aware if someone is having increasing pain and is in that bladder area, that might be a side effect of the medications that they're taking. Myoclonus is this sort of muscle twitching that can develop with patients that are on an opioid, and it can be managed by decreasing the dose or maybe changing to another opioid. Sometimes you might need to add a medication such as a benzodiazepine. I try not to use the benzo medications in older adults because of fall risk and confusion, so I tend to try to do other things rather than use that medication unless it's at the very end of life. If myoclonus develops and the patient has increasing pain medication, and as you're increasing the pain medication, instead of relieving their pain, they start to feel more and more pain. That can be because of the toxic metabolites of morphine with somebody who's renal impaired. So if somebody has kidney problems and you're starting to notice some muscle twitching and they're on morphine, and the more you sort of increase the medication up to manage their pain, they start complaining of more pain. That's something to be very cautious about. And then the last, I believe the last side effect that we have is respiratory depression, which is a concern for a lot of families and patients about when their family members are on opioids. It's rare when the opioid doses are carefully titrated. So if you look back at the charts that we have that say how soon the medication works and when you should titrate it in the lowest dose possible, if you're very cautious and use that low dose and go very slow in your titration, this shouldn't be a problem for you. Patients who have COPD or who retain carbon dioxide may be more at risk, and so that's something to be cautious of. Respiratory depression is almost always preceded by sedation. So if you notice that your patient is starting to be very somnolent and you scale back that medication, that's a good intervention that you can do to avoid the respiratory depression. And so I know we're now at the 1 hour mark. I was hoping I could, as I warned you before, we may not get to the slides on the adjuvant analgesics because I was compressing a 2-hour talk into one. But those slides are there for you as well. So there are medications that you can use in addition to further improve pain control, and I have the geriatric dosages and the names of the medications all there for you as well. And like I mentioned on the very first slide, I have my email address, and you're welcome to send me an email. I'm very, very happy to answer any questions that you have via email. Thank you so much for your time and for this sort of whirlwind tour of pain assessment and management. Thank you, Dr. Talebreza. That was great.
Thank you. If you have a question, please press star then 1 on your touchtone phone. If you wish to be removed from the queue, please press the pound sign or the hash key. If you're using a speakerphone, you may need to pick up the handset first before pressing the numbers. And once again, if you have a question, please press star 1. And we have a question from Sarah Lino. Please go ahead. And the next question comes from Teresa. Please go ahead.
Yes, hi. I joined the meeting 10 minutes late, but I wasn't able to view any of the slides. I tried everything I could, but I couldn't see the slideshow.
If you'd like to enter your email address into the chat function, we can email you a copy of the slides.
Okay, chat function.
You see the chat tab on your screen over on the right-hand side.
And what does it say?
It says chat.
I don't see anything. I have the initial screen, the one that says log in. So do I do that one? And then I tried proceeding and...
Are you on the WebEx event?
Yes.
Okay, so up at the top of the screen, on the right, it says participants chat only.
No,
we're going to click on the chat.
Chat. I don't see a chat.
Or you can give it to me just right now if you don't mind. If you're not here,
I think I better give it to you. It's more simple. There's a chat over here. It's T. It's all small letters. It's T. Castillo at hhsc.org.
T as in Tom, Castillo, C-A-S-T-I-L-L-O, at hhsc.org?
Yes, that's it.
Okay, we can send it to you.
Oh,
thank you.
Thank you. Bye.
Thank you. There is a question about if the slides will be in archive. So will they be? I know that the QAM, QAOs, so also quality improvement organizations, will receive access to the recording and to the slides, and will be able to post those on their website. I'm not sure about the archives, unless there's somebody else on here that knows that can answer that. but you can contact your QAN or QIO.
Thank you. And we do have a question from Nancy. Please go ahead.
Okay, can you hear me?
Yes.
Okay. I do MDSs, and I was wondering, when I do the pain interview, for the pain intensity, a lot of times I'm asking the verbal descriptor scale, which is mild, moderate, severe, or very severe, horrible. And I was just wondering, would it be, I mean, that's pretty much consistent with everybody, but should I be doing the pain intensity with the numeric scale instead?
That's an excellent question. So actually that verbal descriptor scale is validated as well for older adults. So if that works for your patient population, and that is an absolute fine way to assess pain as well. I think sometimes what's nice about the different scales that we talked about is if someone has hearing problems and they may not be able to respond to that question, and you might be able to write that question out for them if they're having problems with that, or for some people that, the other thing I forgot to mention about the FACES scale that can be helpful is for people who don't speak English. So it's been validated to show that FACES scale can help for people just pointing to, if they have vision and they can, and cognition, and they can point to one of the FACES, that can be very helpful. But so from my perspective, the scale you mentioned is validated, and if it's working, great. If it's not working, if the person can't hear, or they can't see, or they don't speak English, then you could certainly try to use a different scale.
Okay. So where would you code, or where would you be with a very severe, horrible on your rating scale then?
I think that would be that 7 to 10 severe on the World Health Organization scale. If somebody's saying very horrible or severe, it would be in sort of that 7 to 10 range for them.
Because I have mild, moderate, severe, and then the next one is very severe, horrible.
Yeah, and I think that, so I would put mild in that same mild category, same with moderate, and then severe to very severe would probably fall under the World Health Organization 7 to 10 scale. The thing that's nice, and about sometimes the numeric scale, is that you can sometimes calibrate it too, where you tell people what's tolerable to you, but I think that that's kind of implied in the verbal descriptor scale too. If my pain is moderate, my pain is very severe or horrible, then that sounds like that would not be tolerable for them.
Okay. Thank you.
Thank you. Excellent question.
Thank you. And as a reminder, if you have a question, please press star 1. And we do have a question from Amy. Please go ahead.
Hi. Oh, hello?
Hi.
Hi. Actually, you have Terry, we're job share together. We're both MDS nurses, and we have some residents that always say, like, verbally that they're a 10, and their body language doesn't, correlate it with it. And we document it, and then on the MDS, you're supposed to say what the resident says. But how would you recommend? Do you have any scale that? I think maybe one of your scales that you offered in here, we can do a verbal one and rate it differently, and because they're laughing and joking with their family members sitting there, but they'll say it's a 10. And I try to explain it like, go ahead.
Oh, no, please go ahead.
No, I would like to hear what you have to say first.
Oh, I just had a question for you. I was curious have you asked them before about, so they say 10, have you ever asked them that question about, well, what's tolerable for you and what do you consider,
I have not. That was really helpful.
I wonder
I think that the 7's tolerable to them, and yet they still, I could see them maybe being a 3 where they're adaptable, or a 4 where they have spikes, in their pain, and then, it comes back to where it's an adaptable level for them.
Yeah.
They fall into a mild category.
Well, I think that's where it gets a little tricky, and I think some of the things that some advice that I would suggest is, we talked about at the very beginning was that there's other factors that contribute to pain as well. So they can be describing pain because there may be a psychological or a spiritual or an emotional or social component as well. And that it doesn't mean that we're dismissing their pain. So we're not saying, you don't have pain. It's that type of pain, the psychological, the social, the spiritual pain, can affect your perception of pain. And if that's unmanaged, then people can oftentimes feel this sort of horrible pain, but the interventions of the medications are not going to address that. So that's where I think getting back to that multidisciplinary setting where we look and say there's some assessment tools, and we focus really just on the physical pain assessment, but looking and saying, well, can we get social work to see if we feel that there is a psychological component? Can there be a social component? And then we can start treating it from all of those different aspects and then see if that might make a difference. Sometimes there can be drug-seeking behavior that can have people, might exaggerate pain to a degree. Sorry, just to clarify, what I was saying before was not an exaggeration of pain. It's just a different pain, a psychological or spiritual pain. Aside from that, some people might be looking to try to get more medication, and sometimes they might, so that can be a possibility with the drug-seeking behavior. Sometimes people, like I mentioned, it's just a matter of calibrating. And so calibrating would be asking them, well, so what is tolerable for you? What is acceptable? And maybe even doing some re-education. If you say, what's your low pain level, and they say 0 and they're at a 10, maybe just sort of helping to manage expectations with them and explain, well, really what our goal is to try to get you down to maybe a 3 or 4. And then the other thing that we can do is look at sometimes the PAINAD was the one that I think you were talking about that looks at, you might have your nursing staff ask the patient a scale and then also give them a PAINAD rating. And so then you can kind of see, well, are they grimacing, are they breathing, are they moaning, or any of those things there, and you can kind of compare those two different types of scales. And then just, sorry, 2 more points, because there may be too lengthy with this answer. Sometimes chronic pain may not look the same as an acute pain, so sometimes people with chronic pain may not have the same sort of responses. But in general, if someone's in severe pain, there should be some sort of functional impairment. So if you look at that slide that we had a while back that showed, there should be some limitation. If someone's up and functioning and walking and smiling and really no impairment in their ability to do any of their activities of daily living, then I think that's where I would really either look at, is there a different source of their pain? Could there potentially be an abuse potential? The TAC-SLAC tool not the TAC-SLAC, but yes, actually, I think it is, I apologize, the TAC-SLAC, the longer tool, the 60-item tool, could be helpful sometimes because it might have some measures of function. And so if you have somebody who is limited with their function and you treat their pain and then they have more range with their function, that's another assessment that, wow, this is an effective pain intervention because it's actually improving function for them. And I think I do have another functional assessment, a pain measurement that's all just about like what was the patient's functional level before and after. And if in the chat screen you can send me your email address, I'll see if I can. Actually, what I'll do is I'll give that to Michelle so she can share it with everyone who would like it. Oh, sure. But thank you. That was such an excellent question.
Thank you. And as a reminder, if you have a question, please press *1. And we do not have any questions in the queue.
Thank you. Excellent questions. And again, the email address is available, and then it looks like we received many people's email addresses, and we'll make sure that those who didn't get the slides, that we get them out to them. Thank you.
Thank you, ladies and gentlemen. This concludes today's call. Thank you for participating. You may now disconnect.